Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to the Deep Dive. Today we're tackling something that's, a really crucial mission for every clinician, especially those of you in acute surgical settings here in the UK.
We're talking about the ReSPECT process.
Exactly. We're going to distill the practical reality of it.
And ReSPECT, just to be clear, stands for Recommended Summary Plan for Emergency Care and Treatment. It's really changed how we approach anticipatory care planning.
Right. And for you listening, whether you're a junior registrar, a surgeon, a critical care doc, our goal here is to really cut through the policy stuff.
And give you the actionable framework, the why, the when, and the how.
Especially within the tight timelines of general surgery.
It's so important because ReSPECT came about from, documented failures in the older processes. Specifically with DNACPR, do not attempt cardiopulmonary resuscitation.
Those discussions were often tricky.
Tricky is a good word. They were often rushed, poorly documented, and they really didn't get to the heart of what the patient actually wanted for their overall treatment.
So this is a paradigm shift.
It really is. It moves way beyond just that one question of resuscitation and helps you create a plan for all emergency care, a person-centered plan.
That proactive approach seems to be the key difference. But before we get into the nuts and bolts, we have to do our mandatory disclaimer.
Of course.
Okay, so this deep dive is for reference only. As a practicing clinician, you absolutely must follow your own local and institutional guidelines and policies. That goes for ReSPECT and, all aspects of patient care.
Couldn't be more important.
So let's start with the basics. What's the one conceptual shift a busy surgeon really needs to grasp about this whole process?
It's that the discussion has to be proactive, not reactive. That's it.
Proactive, not reactive.
We're asking clinicians to have these complex, high-stakes conversations when the patient is actually stable enough to make a meaningful, informed decision.
Not when they're in shock or rapidly deteriorating after an operation.
Exactly. Not in the middle of a crisis.
Okay, so that distinction is huge, but it does bring up some complexity. Assigned DNACPR was effectively an instruction. What's the legal and ethical standing of a ReSPECT form?
That's a vital point. A ReSPECT form is not legally binding.
Not like an ADRT, an advanced decision.
No, not in the same way. An ADRT is legally binding if it meets all the criteria, and it usually refuses a very specific treatment. ReSPECT is different. It's a summary of recommendations, of values, of preferences. It's a guide.
A guide with, I imagine, some serious ethical weight behind it.
Precisely. It provides crucial, documented evidence of the patient's autonomy and their goals. Any healthcare professional in an emergency paramedics, the theater team, they have to consider it.
And if they override it?
They'd better have a very clear, clinically defensible reason, and they have to document it thoroughly.
So it really elevates the whole process. It makes the communication and the documentation systematic, and it looks at the whole care plan, not just CPR.
Yeah, it's designed to protect the patient's voice when they can no longer use it. It gets rid of that ambiguity where, you knew a patient wouldn't want aggressive intervention, but the paperwork only covered one thing.
Which brings us to timing. This is probably the biggest challenge for any busy surgical service, right? How do you fit this conversation in?
Timing is everything, and it has to be driven by clinical judgment. All the evidence shows that discussions held earlier, when things are calm, lead to much better outcomes.
Better than deferring it until the patient is acutely ill.
Far better.
So can we zero in on the specific triggers for a surgeon? I mean, for a young, fit patient having a straightforward appendectomy, this isn't really necessary.
No, it's not. The line is really drawn around risk and frailty.
Okay.
So first, think about the elective surgical context. Any patient on your list with significant comorbidities, severe cardiac or lung disease, moderate to severe frailty, or just advanced age, they need this discussion before the op.
Not on the morning of surgery when they're already anxious and on the trolley?
Oh, definitely not. You need time. You need an unhurried conversation, maybe with family there. Think about an 85-year-old for an elective hernia repair who also has severe COPD.
Right.
Their perioperative risk is high. They need to understand what life might look like if they have a major complication.
Okay, so that's planned procedures. What about our bread and butter, the emergency presentations?
Well, here, you're obviously not having the chat during the immediate crisis. No one should be talking long-term goals while they're actively resuscitating someone.
Of course not.
Instead, you start the discussion promptly after. Ideally within the first 24 to 48 hours once they're stabilized, and this is critical if the patient has capacity.
So the patient with perforated diverticulitis, they've had their emergency laparotomy, they're now stable on the ward, but they're still facing a long recovery. That's the moment.
That is the perfect moment. Another trigger is a new diagnosis of a serious, life-limiting condition.
Even if surgery is still on the table.
Yes. If you're operating on someone with, say, newly discovered metastatic cancer or end-stage liver disease, that discussion has to happen after they've had some time to absorb the bad news, of course.
And finally, you mentioned frailty.
Frailty. It cuts across everything. If a comprehensive geriatric assessment flags moderate to severe frailty, that's an immediate trigger. Frailty is the single biggest predictor of poor outcomes.
So, to sum it up, avoid the crisis, avoid high anxiety moments, and give the patient the time and space to process.
You've got it.
Okay, so now we know when. Let's talk about how. There's a systematic 3-stage framework, isn't there?
There is. And stage 1 is all about establishing shared understanding.
Meaning,
you have to start by grounding the conversation in the reality of their current health, their diagnosis, their prognosis. You're setting the clinical context for the choices ahead.
what's a good way to start that? What's a good opening line?
Something open-ended. I find, tell me what you understand about your diagnosis and what we've talked about so far. Works really well.
And that lets you see where they're at, correct any misunderstandings.
Immediately. And surgically, this is where you have to be really clear about risk. Explaining that, yes, we can do this operation, but because of your heart condition, the risks are significant and the prognosis might still be guarded.
You're linking the clinical facts to their future.
Exactly. And at this stage, you also document any special communication needs, hearing issues, language barriers, and you check for things like an existing ADRT or a lasting power attorney.
Right, an LPA, the person legally empowered to make decisions if they can't.
Yes, that needs to be established early.
Okay, that groundwork then leads into stage 2, which feels like the hardest part. Identifying priorities and goals.
It can be. This is where we move from clinical facts to personal values. It's about quality versus quantity of life.
So you're asking?
You're asking, if you were to become seriously unwell, what would be most important to you? You're trying to understand their core values. Is it being able to talk to family? Is it staying at home? Is it avoiding pain?
And the ReSPECT form itself helps with this, doesn't it? With that visual scale.
It does, and it's a brilliant tool. That scale that balances sustaining life against maximizing comfort. Surgeons should really use it. It makes these abstract ideas really concrete for patients.
It helps you understand if your patient with, say, high-risk abdominal sepsis wants everything thrown at them, or if they'd prefer palliative care if survival meant a very poor quality of life.
That insight is gold. It guides everything that follows.
Which is stage 3. Plan specific recommendations for emergency care.
This is the really pragmatic bit. Planning for a crisis when the patient can't speak for themselves. We talk about specific treatments.
Like, would they accept another emergency laparotomy? Would they want blood products, dialysis, a short course of ventilation?
All of those things. And just as importantly, what treatments they would not want. These conditional preferences are really common.
Can you give an example of that?
Sure. A patient might say, look, I'd accept ventilation for a week if you think you can fix my bowel, but I do not want to be on a ventilator long term if my liver fails completely.
That level of detail is so important.
It's vital. And this is also where we as clinicians document treatments we believe would be futile or inappropriate. For example, recommending against CPR for a patient with end-stage cancer and a very poor performance status.
And finally, their preference for place of care, hospital or home.
Yes, that's a key part of the plan.
The quality of that plan really depends entirely on the quality of the conversation. So section 4 in the process deals with communication skills, capacity, all the logistics.
And this requires a genuine cultural shift. It really does. Surgeons need to use excellent active listening skills. You have to paraphrase, summarize what you think you've heard to make sure you're on the same page.
And empathy. How important is that?
It's non-negotiable. You have to acknowledge the emotional weight of it. Just saying something like, I know this is incredibly difficult to talk about, and I appreciate you sharing this with me. It builds so much trust.
What about language barriers? I know a lot of places still rely on family to interpret.
That is a huge clinical risk. You must use professional interpreters. Relying on family, well, it risks miscommunication, privacy breaches, or family members trying to shield the patient from the reality of the situation.
And the setting matters. This isn't a quick chat on a busy ward round.
No. This needs 20 to 30 minutes minimum in a private space. If the conversation feels rushed, the whole thing loses its ethical integrity.
In terms of language, how do you make it a shared decision, not an imposed one?
You avoid prescriptive statements. So instead of saying CPR won't work, so we're recommending against it, you frame it around their values.
So you'd say something like,
Based on what you've told me about prioritizing comfort, and given the very low chance of success, our medical recommendation is to focus on other treatments rather than CPR. Does that feel right to you?
much better. And before we document anything, we have to confirm capacity. Can you just quickly remind us of the 4 points for that?
Of course. The patient has to be able to understand the information, retain it long enough to make a choice, use or weigh the information, and communicate their decision.
And if they lack capacity?
Then you involve surrogates. If there's an LPA for health, they're the decision maker. If not, you talk to family. But the key is that the discussion has to be about what the patient would have wanted based on their values.
Not what the family thinks is best.
Not what the family thinks is best. It's called substituted judgment.
And then the documentation itself is very systematic.
It is. The form covers everything. But the logistical part is so important. The original form must stay with the patient.
The paramedics can find it.
Exactly. And copies need to be shared with the GP and the ambulance service. If they can't find it in an emergency, the whole conversation was, largely in vain.
Okay, so moving to our final section. This plan isn't set in stone, is it?
Absolutely not. It has to be reviewed. Whenever there's a significant change in the patient's condition, a new diagnosis, or even a move between care settings.
And if a form is canceled?
It has to be clearly marked, canceled, with diagonal lines dated and signed. No ambiguity.
This brings us back to that high-stakes moment, the perioperative period. What happens to a ReSPECT form when a patient is on the operating table?
This is a critical point. The surgeon and the anesthetist have to formally review it beforehand. And it's very common practice for a DNACPR recommendation to be temporarily suspended during the operation itself.
Why is that?
Because the chance of a successful resuscitation in a controlled, monitored environment like an operating theater is often much, much higher than on a general ward.
But that decision can't just be assumed, can it?
No, absolutely not. That temporary suspension and the exact point it gets reinstated, whether that's in recovery, on the ward the next morning, that has to be explicitly discussed with the patient and documented clearly.
We know a lot of clinicians, feel a bit reluctant to start these conversations. Let's tackle the barriers. What about the fear that you're just going to upset the patient?
It's a really common concern, but the evidence just doesn't support it. Overwhelmingly, patients welcome these conversations. They feel respected. They feel their care is personalized.
And avoidance actually causes more distress later.
It does. For the family and for the staff, who can suffer from more injury when they feel they've delivered unwanted care.
And what about the big one? I just don't have time for this.
You have to reframe it. It's not a cost. It's an investment. Yes, it's 20 or 30 minutes now, but that proactive chat prevents hours of distressing, chaotic, legally risky conversations when that patient suddenly deteriorates without a plan. It's an investment in safety and efficiency.
That's a great way to look at it.
To just synthesize all this for our listeners, for a general surgeon, getting to grips with ReSPECT is, it's a modern professional obligation. It's the gold standard for personalized, goal-concordant care. It's about honoring your patient's autonomy.
Okay, so here's a final thought for you to take away and mull over. Integrating ReSPECT effectively requires teamwork. It requires collaboration. So how will you proactively involve your multidisciplinary colleagues, palliative care, geriatricians, critical care, to make sure the plan for your most complex surgical patients is as robust as it can possibly be?
Really important question.
We really hope this deep dive into ReSPECT was informative and actionable. If you like this content, please don't forget to share with at least one of your colleagues or friends and help spread the word. And also, check out our YouTube and other social media pages for more material. Until next time.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.